Hello and welcome everyone to lecture 38 of this series on fluids and electrolytes. This series accompanies my book, Manual of Fluid, Electrolyte, and Acid-Base Disorders, a pathophysiologic approach to common clinical problems. I am Dr. Mohammad Tinawi. I am a nephrologist in Northwest Indiana. This is the book. You can find more information on how to get it on Amazon in the description below. Now we are starting a new chapter today, chapter 6, which is calcium metabolism disorders, hypocalcemia and hypercalcemia. This is lecture 1 of this chapter, and it is an introduction to the subject. Calcium is a divalent cation, as you all know. It plays a very critical role in many body functions: mineralization of the skeleton, signal transduction, nerve conduction, muscle contraction, even blood coagulation. You know, if you chelate the calcium from the blood, it does not coagulate. If you add citrate to the blood, like they do in blood banks, it does not clot. Calcium metabolism is tightly linked to magnesium and phosphate metabolism, as we shall see. Calcium homeostasis is dependent on 3 things. You have intestinal absorption, then you have bone turnover, and then finally renal reabsorption of calcium. Calcium, unlike magnesium, is tightly hormonally regulated by the parathyroid hormone, or PTH, the calcitriol. Another name for it is 1,25-dihydroxy vitamin D. Okay, this is 1,25-dihydroxy vitamin D3 is calcitriol, and also serum ionized calcium. So these 3 factors regulate calcium. Cloning of the calcium sensing receptor has greatly advanced our understanding of calcium metabolism. It's not difficult to diagnose hypocalcemia or hypercalcemia because calcium is included in regular routine chemistry panels. Now, to ascertain the diagnosis, you really need to measure ionized calcium, although we don't do that often enough. But really, hypocalcemia is low serum ionized calcium, and hypercalcemia is elevated serum ionized calcium. As we shall see, albumin, low or high, can interfere with total calcium, while sometimes ionized calcium is normal. So if you can measure ionized calcium, it's preferable. It's not readily available. It takes some time. So oftentimes we rely on total calcium that is included in regular chemistry panels. Now, what is a normal serum calcium? Normal serum calcium is 8.8 to 10.4 milligram per deciliter. If you want to convert to milliequivalent per liter, all you have to do is to divide by 2. So normal would be 4.4 to 5.2 milliequivalents per liter. Now, if you want to measure it in millimoles per liter, you divide by 4. So normal would be 2.2 to 2.6 millimoles per liter. So again, to convert from millimole to milliequivalents, you multiply by 4, which is the valence of calcium. We said calcium is divalent. And to convert from millimole to milligram per deciliter, you multiply by 40, which is the atomic weight of calcium, and then you divide by 10, or simply you multiply by 4. Now, ionized calcium is about 1/2 of total serum calcium. So serum ionized calcium is 4.4 to 5.2 milligram per deciliter, or half of that will be milliequivalent per liter, or half of milliequivalent per liter will give you 1.1 to 1.3 millimole per liter. Now, there are 3 forms of serum calcium: ionized or free, which is about 1/2, accurately 48%, about half; protein bound, and this is mostly bound to albumin, less so to globulins, about 45%. The rest, which is 7%, is complex to citrate, oxalate, carbonate, and phosphate. Now, ionized calcium or free calcium and complex calcium are diffusible and can be ultrafiltrated by the kidney, while protein bound or albumin bound calcium is not. It cannot be diffused, it cannot be ultrafiltrated. So This is a diagram of the three forms of serum calcium. As you can see, about a half or 48% is ionized or free. 45% is albumin bound, a little bit to globulin, but mostly albumin bound. And this portion is not diffusible and not ultrafiltrable by the kidney. And 7% is complex to citrate, oxalate, carbonate, and phosphate. Calcium and serum albumin. Intracellular calcium is bound to calmodulin and other calcium-binding protein. Although this is a very small portion of calcium, it's extremely important. Okay, albumin. If you have low albumin, if you have hypoalbuminemia, you are going to have hypocalcemia. Why? Because total calcium is going to decrease, not ionized. Ionized will not be affected. So you have a decrease in protein-bound calcium or albumin-bound calcium. So how do we correct for that? Well, we use this formula. We get the total serum calcium. Okay, how do we correct for that? You get measured serum calcium and then plus 0.8, and you multiply that by 4 minus serum albumin. Let's take an example to illustrate this. Let's say that we have a patient with a serum calcium of 7.8 milligram per deciliter, but this patient has really low albumin of 2.5 gram per deciliter. So we say corrected calcium is 7.8, and then we add 4 minus 2.5 is 1.5 times 0.8. We add that to 7.8, so we get 9. Therefore, total serum calcium is normal, and we don't need to replace calcium. Okay, in other words, for each 1 gram decrease in albumin, we add 0.8 to measured calcium, and this is how we correct calcium. So, if we are measuring calcium, and let's say it's 6, and albumin is 2, we are going to add 0.8 plus 0.8, so 1.6. So 1.6 times 6, we get 7.6. Okay. Now, the reverse is true. So an increase in albumin by 1 also will lead to a 0.8 increase in total serum calcium. And we can correct that the same way. So if albumin is 5, we are going to take measured calcium, and then to correct it, we say, let's say it's 10 minus 0.8 is 9.2, and that would be normal. Now, studies have been done, and in patients with chronic kidney disease, especially stages 3 to 5, this formula is not very accurate. So this is a good approximation, but if you're not sure, if you really want to know what's going on, if you have severe hypercalcemia, you want to confirm it, please check ionized calcium. Check it one time, okay, for verification. You don't have to check it every time. So let's discuss calcium distribution in the body. Now, in the body, there's about 1,000 grams, about 1 kilogram of calcium. Okay, so 1,000 to 1,300 grams of calcium are present in the body. So calcium is the 5th most abundant element in the body. Where is calcium? Well, like everyone knows, it's in the skeleton, it's in the bone and teeth. Now, only 0.6% is in the soft tissues. In the extracellular fluid, only we have 0.1%, a really, really tiny amount. And in the plasma, we have 0.03%. Even though the amount is tiny, it's very critical for cellular function and nerve transduction, like we said before. Intracellular calcium is very low, 100 nanomoles, okay? And it is essential for muscle contraction, coagulation, etc. Now, in the skeleton, in the bone, and in the teeth, calcium is complexed with phosphorus, and it forms hydroxyapatite, and this gives the bone its mechanical strength. Now, only 1% of the calcium in the bone can immediately equilibrate with extracellular calcium, so the rest of it is not immediately available. What about incidence and prevalence of calcium metabolic disorders? Hypercalcemia is fairly common in the general population, 1 to 4%. In a hospitalized population is 0.17% to 3%. Now, hypocalcemia is even more prevalent in hospitalized patients, can be up to 10 to 18%. In some intensive care units, it can be up to 70 to 80%. Why is that? Well, many patients in the ICU, up to 65%, have hypomagnesemia. Like we said before, you have malnutrition, you have use of diuretics, and hypomagnesemia is linked, like we said, to hypocalcemia. So whenever you have a problem in magnesium, you are going to check calcium and phosphorus. And these three things, magnesium, calcium, and phosphorus, kind of go together. And if you have a big problem in one, you have to investigate what's going on with the other two. Now, I'm going to stop here, and we are going to discuss in the following lecture calcium homeostasis. See you then.